Thank you, Sunanda, for nice introduction. It's a pleasure for me to come here to this very good session. I will start my screen share. Yeah. So, greetings everyone, my esteemed colleagues, ladies and gentlemen. Firstly, I would like to thank the organizing committee to invite me in this prestigious congress. Thanks to Dr. Sunil Pandya, Professor Sunanda Gupta, Bapak Niko Dali. My name is Susilo Chandra, Anaesthesiologist from Indonesia. Today, I would like to share our experience regarding the enhanced recovery after surgery pathway for C-section. For the past 2 years in Indonesia, enhanced recovery pathway has been widely introduced worldwide, including in Indonesia. We have introduced ERAS pathway for C-section since 2019. There were times when cesarean section was horrific, traumatizing surgery for pregnant mothers, and many patients decided to opt out of surgery because they were scared. Many pregnant mothers who have to undergo cesarean section feel starved, dehydrated, cold, weak, in pain, nauseous, surprised, unprepared. And it is our job as anesthesiologists to change this condition. And as time goes by, we have many improvements in terms of our perioperative care, including for pregnant mothers. Currently, patient feels more prepared, more informed, warm, stronger, hydrated, out of bed sooner, no intraoperative or postoperative nausea and vomiting, and minimal postoperative pain. Enhanced recovery after C-section has been widely introduced in Europe and UK since 2012 and started in the United States in 2018. And in Indonesia, we have started introducing enhanced recovery after C-section in 2019. I did it like over than 500 cases since 2019, but I found if we do it by just in colleague time, it's better. We found that based on our experience, in order to have a successfully implement the enhanced recovery after C-section pathway, is a top-down policy, not bottom-up. So you have to ask the involvement of hospital administration from the beginning. Because it is similar to other enhanced recovery after surgery pathway, multidisciplinary approach is essential. Obstetricians, pediatricians should be familiar with the pathway. Involvement of nurses and midwives should be from the beginning. Nutritionists also plays important role during enhanced recovery after C-section. Education materials, leaflet, or video is beneficial for the prospective patients. This is an example of hospitals who, from the beginning, hospital management involved. They built the system. They have a multidisciplinary team, and they also do a monitoring and evaluation system. This all happened only a week after my first webinar on enhanced recovery after C-section on August 2020. As we all know, enhanced recovery after C-section composed of preoperative components, intraoperative, and postoperative components. In enhanced recovery after C-section, all three components are very, very important. All components must be conducted in order to have optimal outcome. No component is more or less important than the other. Anesthesiologists play a role of 2 elements on preoperative period, 4 elements in intraoperative, and 5 elements in postoperative period. Let us discuss one by one. Anesthesiologist is often consulted at the very last before surgery, even sometimes in the prep room. But in enhanced recovery after C-section, we should take responsibility from the beginning. We should assess the patient and decide whether they are fit or not fit for surgery, including pregnant mother. One of the highlights from enhanced recovery after C-section pathway is to limit fasting, or even I would like to suggest name as no fasting. What does it mean? We administer non-particulate carbohydrate loading 2 hours before surgery. Patient will have no thirst or hunger whatsoever prior to the surgery. I believe there are commercial prep drinks available worldwide. However, in Indonesia, we ask the nutritionist to create this drink by using maltodextrin. So if you don't have commercially prepped drink, then don't worry. Then what we can do intraoperatively? To prevent hypotension due to spinal anesthesia, in my daily practice, I have introduced low-dose spinal anesthesia, which can prevent intraoperative hypotension, which later can prevent also intraoperative nausea and vomiting. I have regularly conducted a low-dose spinal for C-section, hypotension, and later intraoperative nausea and vomiting can be prevented. Usually I give 7.5 milligram of bupivacaine combined with fentanyl 20 microgram and 100 mic of morphine. There are many devices to prevent hypothermia or maintain normothermia. The use of IV fluid warmer, forced air warming device has been introduced. Based on Joint Commission guidelines, maintain the operating theater room within 23 degrees Celsius with appropriate humidity, and please do active warming preoperatively. For the IONV or PONV, use multimodal prophylaxis even from the beginning of the surgery. Combination of metoclopramide, dexamethasone, and ondansetron, and I add one more hidden treasure drug, haloperidol, is essential to prevent intraoperative and postoperative nausea and vomiting. Multimodal analgesia should be commenced from the beginning. I usually use 100 mic of intrathecal morphine. Please don't forget to give intravenous non-opioid in operating theater, such as paracetamol and NSAID, unless contraindicated. If you don't like to give morphine intrathecally, please consider local anesthetic wound infiltration or regional anesthesia, such as TAP block or KL block, depend on your preference. Now, postoperatively, there are some issues that we have to involve with. Oral intake should be introduced even from the recovery room. Start with mineral water or hot tea in the recovery room, then continue regular meal in the ward. Ambulation can be started early, even in the recovery room. When we administer low-dose spinal anesthesia, patient can ambulate 30 minutes to 1 hour post-surgery. This small gesture can motivate mothers to ambulate freely in the ward because they feel little or no pain at all, thanks to multimodal analgesia. Now you will ask me, how about post-dural puncture headache? Based on this journal published in 1992, almost 30 years ago, the use of small gauge needle have minimal incidence of PDPH. Additionally, I believe most of us have used traumatic needles in our daily practice, so we don't have to worry about PDPH anymore. Resting period is very important for postpartum or post-surgery, not only for cesarean section. This should be routinely introduced in the ward. We all know the side effect of opioid can prevent by avoiding the use of opioid postoperatively. When we have started the multimodal analgesia from intraoperative, I can ensure you all that we can avoid opioid postoperatively. We can avoid this misused drug for our postoperative pain by administering appropriate multimodal analgesia. Return bowel function can be achieved by early oral intake starting in the recovery room as I have mentioned previously, give non-opioid analgesia, start from intraoperative. And lastly, monitoring and evaluation are very important, and we often forget. We always learn from the past success and mistakes. Hence, evaluation is very important from both patient and our colleagues. This is an example of evaluation form that we can administer. Simple and very concise. Please, patient do feel pain or nausea and vomiting, dizzy and shivering, because this is the patient will fill the form by herself. This is from 6 to 11 question. From this 11 question, we know that how all patient satisfied with this pathway. So are we ready to implement ERAS recovery after C-section now? The answer is on my next slide. Our colleagues from Uganda, not just ready, but they already did RCT of enhanced recovery after surgery on C-section versus standard of care recovery from emergency cesarean delivery. Emergency cesarean delivery, not elective. They conclude the use of enhanced recovery after surgery protocol for women undergoing cesarean delivery in a low-income setting is feasible. Reduce the length of stay without generally increasing the complication rate. So, better late than never. As a take-home message, enhanced recovery after C-section is very good clinical pathway that make all patients satisfied. If you want to start, please make it as a top-down policy, not bottom-up. Work as a team leader better than before. All team will be happy with the outcome. No elements in anesthesiologist role are difficult for us to do. Lastly, I would like to thank again the organizing committee for this opportunity, and hopefully my presentation and experience will benefit many of you. For this, I thank you for your attention.
What are your challenges when you implement ERAS protocol?
The only challenges, the only barrier is ourselves. And then obstetrician, pediatrician, nutrition, nurses, and last but not least, hospital management. So we have to encourage them. We have to explain everything before we can do it smoothly. So firstly, I did only with two surgeons, two obstetricians. Just that we cannot add another obstetrician. But after I found, why don't I ask the hospital management to come and see the result of what we are doing? Then suddenly after the top hospital management say, we will do it, this is the very good things we do, and then suddenly everybody use it. The surgeon, the patient, the hospital also happy because the patient, firstly, because it's patient-centered. Patient very happy. They can, especially in pandemic era, that patient want to send home early. We can do it. We can do it one day after surgery. The patient can go back home with the baby. That's all I did.
Discharge them on the second day of surgery. Are there any concerns about the patients coming back with complications or, post-delivery delayed complications? Have you ever encountered such patients who are readmitted to your hospital?
Thanks God, till today, no case at all. And this idea is already spread now, not just in Jakarta, but in the big city, from the west, Papua, to the Aceh. So everybody happy with this. And if you find in social media like YouTube, Instagram, you will find the testimony of the patient. From there, so the patient now asks the obstetrician, can you do enhanced recovery after C-section for me? Because everybody seems happy with the pathway.
Now, another issue which we commonly face in India is the patients have private insurances, and the private institutions where they get admitted, the institution doesn't want to leave them for 5 days because they are losing out on money when they discharge them early on the second day.
Oh. Yeah, it's very it's very difficult to answer, but I think yeah we should because they are private insurance, so we no choice, just do
Yeah.
it. But the patient someday will not happy with that because she's already can walk 6 hours after surgery, and we can put out the urine catheter, and the patient can bond with the baby happily.
And the carbohydrate drinks that you use, do you use glucon D or just fructose?
We use maltodextrin, Sunanda. Maltodextrin combined with fructose
Okay.
because it is good for also for the diabetic patient. It's not
So do
increased.
you use all the elements, 4 plus 5 plus 9 plus 11, all the elements that are advocated, or would 4 or 5 elements be enough to, you know, produce those effects of ERAS? What is your experience?
My experience is the best one is all if all elements is doing by our anesthesiologist, pediatrician, obstetrician, nurse, midwife. But don't worry, start with us first. We do our job like give a ERAS drink, no fasting at all. We give make sure that no hypotension happen. We make sure that no ion fee and pond fee. I think that's a good thing to start. Then the obstetrician say, "Oh, this is very good idea." Then they start to also we give the paper of a journal from everywhere. Then they started to do it again also for the elements.
Thank you so much, Susilo. Angelina, would you
Yeah,
like
there's
to add?
a question in the chat box, ma'am, which says, can NSAIDs be given with low molecular weight heparin and indwelling epidural catheter?
Yeah, in enhanced recovery after C-section, usually they suggest that we do not epidural but spinal anesthesia, because epidural may sometimes, if we are unlucky, the catheter is migrate, so it can do the dura mater, and so maybe happen a PDPS or something else. So we only do with spinal, and if you want to give low molecular heparin, it's okay because it is spinal. Maybe 6 hours after surgery, you can do it.
I think that was directed towards Sandeep.
Possibly.
Yeah, that was not with
Yeah,
ERAS, I think.
yeah.
I think that.
I'm sorry, Dr. Sunanda Gupta, I didn't hear that.
Okay. Yeah, here, Sandeep. Can you repeat the question?
Yeah, sure. It says, can NSAIDs be given with low molecular weight heparin and indwelling epidural catheter?
Okay, so actually I'm sorry. Actually, the guidelines are that.
Sandeep, you can come live so that we can see you while you answer the question.
No problem with yourself.
Yes.
So actually, the guidelines for using the NSAIDs are you should not use NSAIDs on long term because of the risk of GI bleeding. So my suggestion is that for short term, yes, even including COX-2 inhibitors, yes. If at all you have got any worries about the APD, acid peptic disease, or even GI bleed, I would strongly recommend using COX-2 inhibitors, provided there are no contraindications. Because first and foremost, the best NNT with the COX with any NSAID is with the COX-2 inhibitor called as itorecoxib in the dose of 120 milligram. The NNT is 1.7, which means that's the best NNT one can ever have with the NSAID. If you compare with paracetamol, it goes to around 8. If you compare to dihydrocodeine, it goes to 12. Diclofenac goes to around 3.5, 3.4. So you cannot get better than itorecoxib. So I would suggest that if you have got an indwelling catheter or if the patient is on low dose aspirin, I would use the NSAIDs with caution. But at the same time, if at all I want to use it, I would use it as a COX-2 inhibitor. And there is some data to suggest that, to support that. And I mentioned that a little bit in my talk anyway.
Yeah. Another drug which you talked about was duloxetine.
Yeah, so duloxetine SSRI, selective serotonin reuptake inhibitor.
How effective do you find them in your chronic pain patients?
So usually these medications are, it's very difficult to get the license to use in the chronic pain medications. But duloxetine has done that. So duloxetine is licensed to use in fibromyalgia.
Across the counter, it's available.
Well, I mean, nothing works 100%, so I can't say that it works 100% in the 100% of the patient. But yes, duloxetine, the very fact is licensed for use in fibromyalgia. I have used it left and right in fibromyalgia, duloxetine, provided there are no side effects. Usual side effects are initially observed, like probably sedation, but they are very mild. I mean, it's tolerated very well. Constipation, it's very well tolerated, duloxetine, fluoxetine. My choice actually is that use the cheap one. So I start with nortriptyline more than amitriptyline because nortriptyline is less sedative theoretically than amitriptyline, provided again there are no contraindications. And I do use some kind of adjuvant with that, like anticonvulsants, pregabalin, gabapentin, or sometimes fluoxetine, duloxetine. I don't use duloxetine unless I've got a license for fibromyalgia. Because ultimately chronic pain patients, I don't want them to have many medications, and I'm quite a big of interventionalist. So wherever possible, I go for interventions because it will minimize the use of the oral medications, especially in postoperative or postpartum period, where you want to limit the medications for the concern of the effects on the baby. And as I said, if I use any intervention, for example, occipital nerve block, for migraine or headache, which is very common in women, I limit the medication use in the postpartum period, which is great. And it's very simple, very easy to do. I will always do it ultrasound guided because it's very easy rather than landmark techniques. Just see the artery and go lateral or medial, wherever you want to go. Just inject 5 ml of local anesthetic steroid. And as I said, like steroid, no, it's yes, because we use 40 or 80 milligram at a time, and that's it. I mean, you are talking about one injection using 40 or 80 milligrams of methylprednisolone or triamcinolone, and that's good enough. I've used it in cluster headaches also to top it up. I mean, cluster is a very difficult condition to treat, but it works actually well in occipital nerve blocks, work well in cluster headache. I must confess, and I have to be upfront here, none of the interventions I will give 100% guarantees to the patient because it doesn't work in 100% patient, but it can be a big adjuvant.
Thank you so much, Sandeep, and thank you so much, Susilo, for being here with us. And I think now we close the session and
thank you, madam.
The proceedings to Dr. Anju Brewal there, our next session coordinator. Welcome, Anju.
Thank you, ma'am. Thank you so much. A very good afternoon to all of you. An excellent talk, Dr. Susilo.
Thank you.